Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday, and I think you get the habit of what's happening Sunday. We have our weekly newsletter. Today we are going to discuss the 5 questions we posted last week. And we started this last week. Today I will give you the 5 questions for the next week to be newsletter number 12. And then every week will be the same to get you a chance to practice question and then to give your answer and wait for the correct answer with the concept about it and explanation for it. As usual, you will see the tags down here. You will see the previous newsletter left side. You can download it from upper right side from this clip. With that being said, let's just start. First question from Operative. The gradual decrease in marginal leakage of an amalgam restoration is primarily the result of. And here is the keyword. In this newsletter, I will give you questions with concepts. It's important for you to read the question carefully. And most of those questions, you can conclude the answer. I cannot tell you, okay, you can see it here. I will give you a reference and then we read it together to conclude the answer. And this is the style of the question recently in the exams. You will see easy question, you will see super direct question, but some question will be like, as you can see now, like it's gradual decrease. So meaning like not initial. And now you will see the difference between both words. Using cavity varnish under restoration, completely correct, but not for gradual decrease. This is used like the first step while you're doing the filling, you use it. Expansion of amalgam alloy, no. Formation of corrosion byproduct, maybe. Formation of tarnish on the surface. So tarnish, nah, but like on the surface, so it's not the correct answer. So let's first get to define corrosion and tarnish and what's the difference between them so we can think about the answer here. So this is what's happening inside your amalgam. Microstructure of 7-year-old conventional amalgam alloy filling. The various phases are marked. Note the extensive porosity and that the gamma area has been replaced by a SNCL corrosion product. You see this one is replacing this one. So let's read it in English. So amalgam restoration often have tarnish, which is the result of silver sulfide forming on the surface and does not affect or change the mechanical properties of the amalgam. So tarnish is a surface property, has nothing to do with the mechanical properties. Otherwise, corrosion, on the other hand, has a negative effect on the properties. Most common corrosion products found with conventional amalgam alloy are oxide and chloride of tin. These are found at the tooth amalgam interface and within the bulk of amalgam restoration. So now we conclude the difference between tarnish and corrosion. So let's see what's happening here for the liner and cavity. For this reason, cavity varnish are used to reduce the cross leakage that occurs around a new filling. So amalgam does not adhere to the tooth surface, so we want to reduce the leakage. So we are going to use cavity varnish to reduce this one at the beginning of the filling lifetime. But if the amalgam is poorly inserted, probably inserted, like there is no breakage, like it was probably tartrated, condensed inside the cavity, moisture contamination is correct. So leakage decrease as the restoration age in the mouth. They may be caused by corrosion products that form in the interface between the tooth and the filling, sealing the interface, thereby preventing leakage. So here we can confirm that the corrosion product replacing the gamma 2, when this happening, this will reduce the leakage. Why? Because it's filling the gap between the restoration itself and the tooth. So that's why with aging, the amalgam will stay longer. And this is not for the conventional amalgam because conventional amalgam does not have the copper, which copper acts as a scavenger to reduce this, we speak about it. But they found that the leakage decreased later because of the corrosion happening between the tooth surface itself and the amalgam restoration. So formation of corrosion byproduct here. Expansion of amalgam alloy, no, I don't want to waste your time here, but the net amalgam restoration is contraction, not expansion, and then we can discuss this concept in a different question. Using cavity varnish, we said this one is correct if it's not gradual. If this one asking about control of the leakage initially, but the gradual, like we use age of the amalgam, so it's formation of corrosion byproduct. Second question from pharma, and you will see now 3 questions back to back from pharma with concepts I would like you to understand it, and this is I told you this before, like pharma question in the exam, it's come in three categories. First category, most common category, you can see in the exam, direct question. This drug working where this drug is used to treat which condition. Second category, which is like really tricky, a little bit concerning, like you can think about it like enzyme inducer, enzyme inhibitor, and relation between them, when to use this drug, when to use that drug. And the third one, which is the most difficult one, which is not very common, but people tend to think about it because they tend to think about it after the exam, which is drug-drug interaction. When you speak about side effect of of a specific medication and a specific age, which is like clinical scenario. And this is tricky question. I would like you to pay attention to those type of question, because when you solve it, you feel very confident during the exam. Which of the following drugs is responsible for producing symptoms of lethargy, agitation, seizures, and fulminant hepatitis? Oh my goodness, this is so tricky. Like when you read this all, you feel like, oh man, like what is this syndrome? Like basically, what is this syndrome? And then you can go to read the option: aspirin, ibuprofen, amoxicillin, phenytoin. And this question is a little tricky because you can say it's pharma, it's oral pathology in a way, but like most commonly it's a pharma, because like this syndrome is describing Reye syndrome. What's Reye syndrome? Reye syndrome, as you can see from this picture, happening most commonly in kids, leading to liver damage and encephalopathy, meaning like brain damage. This happening because our patient has like chickenpox or viral infection or flu, and then we give him aspirin as a painkiller. We give him aspirin to control his pain. This might lead to this Reye syndrome, which can damage his liver and his brain, and giving him diarrhea, vomiting, rapid breathing, seizure, and convulsion. So, how we can manage this syndrome and how to treat it? So, as you see, it's a rare disorder that affects all organs of the body, but is most harmful to the brain and the liver, causing acute increase in the pressure within the brain, and often massive accumulation of fat in liver and other organs. Reye syndrome is defined as two-phase illness because it generally occurs during recovery from a viral infection such as flu or chickenpox, developed 3 to 5 days after the onset of viral illness. It's primarily a children's disease. Although it can occur at any age, it's often misdiagnosed. Why? Because symptoms like it's very broad: irritability, restlessness, disorientation, lethargy, memory impairment, tachycardia, seizure. So when a kid coming to you with all this, you are super confused here. So that's why medical history is extremely important. So you ask the parents: did he has any flu attack recently? Did he has any like viral infection recently? Did you give him aspirin for this? And voila, you catch it. So if he has viral infection and he get the aspirin, it might lead to this one. Is unknown, causes unknown. Studies have shown a link between aspirin and the onset of Reye syndrome. Because of this association, healthcare professionals do not recommend the use of aspirin for children, not anymore. There is no cure for Reye syndrome. Treatment focused on preventing brain damage. Recovery is directly related to the severity of the swelling of the brain. So this condition has no treatment. You just let the patient recover by himself. It's self-limiting, and you try to like deal with the brain swelling because this is extremely dangerous, and it will make some permanent damage for your child. So you should avoid it from the beginning. If patient has a viral infection, we don't give him aspirin as a child. And like I cannot remember like anyone giving aspirin as painkiller for the children, or maybe adult even. Like aspirin now is used as like to control bleeding. Patient was like um, angina, stuff like this. Most commonly is not used nowadays for this treatment as analgesics. So I know this question is tricky, but if you know the condition, it will be, can I say easy? I won't say easy. It's not easy, but this is the type of question I told you about. And do not freak out. This type of question is not very common in the exam, but like when you see it and you solve it, you feel like I'm in a very good position now. So it's aspirin and this condition, Reye syndrome. We don't give aspirin for children, and we don't give aspirin as a painkiller anyway. Okay. Third question from pharma also. Which of the following statement is true? Concurrently prescribing penicillin and tetracycline will increase the effectiveness of penicillin. So let's stop here and try to like think about it. So how you can say antibiotic will increase the effectiveness of other antibiotic? So we said it has to do with like it's bactericidal, or bacteriostatic, bactericidal, and combination between them. And this has a very simple logic about it. Bactericidal is killing the active bacteria by like doing spores, doing interfering with whatever here, but like it's killing bactericidal. Bactericidal, okay? Bacteriostatic is interfering with the protein synthesis, dealing with bacteria on a different level. So if you give your patient bacteriostatic and bactericidal, you are not giving him the full capacity of both antibiotics. You're giving him medication that will not be super effective. Why? Because the bactericidal one need active bacteria to kill it, and bacteriostatic will give this penicillin a little active bacteria. So you are giving a weapon and then you are hiding the enemy. So it will be not super effective. So the whole concept here, like we cannot give bactericide or bacteriostatic in the same time because like one will mask the bacteria and make it hidden from the other side. So you are wasting one antibiotic here. So the general guideline here, you give bactericidal, or bacteriostatic to come in the same conclusion here. And penicillin and tetracycline like come from different families, so you cannot say this one with this one, and usually we don't give this together. Oral administration of metronidazole result in almost 100% absorption into bloodstream. And I think like once you read this line, you feel like, man, this is so weird. How come this is true? And this question, I really intend for you this question. When you read information option in the exam, you have no clue about it, go by exclusion. So we come to conclude this one is not correct anyway. This one, I have no idea what he's speaking about here. Let's read other option. Azithromycin is the drug of choice to treat oncogenic infection. Like drug of choice, oncogenic infection, we know is penicillin. We might go to azithromycin if your patient have problem with penicillin, but we know the golden standard for oncogenic infection is penicillin. Ampicillin is only available for IV injection. This is also incorrect because we know ampicillin is available as tablet. So it's not IV only. So here you have 4 information. 3 you know are not correct. And 1 you have no clue about it. So please do not say, okay, I don't know this information, so it might be penicillin and tetracycline can be used together. No, you know from your knowledge, from your what you have studied, from your hard study, you know penicillin and tetracycline cannot be used together. And even from your clinical experience, you never see penicillin and tetracycline in the same prescription. You don't give them together. It's either or. So here we have 3 information are not correct. So do not hesitate to pick this one. You have no clue about this one, but the other option are not correct. So please, when you conclude this information is correct and you don't know it, but other option are not valid, do not hesitate to pick it. Okay? Let me give you the reference here. Metronidazole given orally is absorbed almost completely, with bioavailability more than 90% for tablets. Absorption is unaffected by infection. Rectal and intravaginal absorption are 67 to 82 and 20 to 56 of the dose respectively. Metronidazole is distributed widely and has low protein binding, less than 20%. And then he goes to speak about it. So here the information I want you to know, like the bioavailability of oral metronidazole is more than 90%, which was like almost 100%, which is like not usual with oral medication, but as you can see here. And please, again, this question just to train you, when you have option make no sense, do not pick it because like I don't know about this one. You don't know about this one, but you are sure other information are not correct. Okay, so this question answer is oral administration of metronidazole result in almost 100% absorption into the bloodstream. Fourth question, again from pharma. Patient requires antibiotic prescription to treat an oncogenic infection. The patient currently taking digoxin for congestive heart failure. Which of the following antibiotics should not be considered? And this one is classic drug-drug interaction. And digoxin is extremely dangerous medication because it's zero kinetic. I don't want to waste your time here, but like digoxin, lithium is like it's red flag. You should know about them, how we're gonna use them. Like drug-drug interaction of these 2 medications are extremely important. I would strongly suggest you read it carefully and you know everything about these 2 medications specifically. So which antibiotic cannot be considered? So shouldn't be considered. Like it's like in another way you can say contraindicated, and I will let you know why we said should not be considered, not contraindicated, because like to be clinically like accurate. amoxicillin, clenda, metronidazole, erythromycin. Let me give you the reference here. So here we speak about the drug interacting a medical condition and effect. Antibiotic, especially erythro, clarithrol, and tetracycline. Please pay attention to these three names. And digoxin. Digoxin is used for congestive heart failure. So what's happening? Alter the GI flora and retard metabolism of digoxin in roughly 10% of patients, resulting in dangerously high digoxin serum level that may persist for several weeks. So it's only in 10%, which is not like a huge number, it's 1 out of 10, but it will lead to dangerously high digoxin serum level that persists for several weeks. And as we said before, digoxin is a zero order kinetic drug, which is like a big deal about it. It like has a very safe margin. Like you should go within the limit. If you go a little higher, toxicity happen right away for this patient. As you can see, several weeks. So patients should be cautioned to report any sign of digitalis toxicity, salivation, visual disturbance, and arrhythmia during antibiotic therapy. It's safe and 90% should have digoxin level monitored during antimicrobial therapy. And I think now you can conclude why we didn't say contraindicated. No, it's not contraindicated, but like should not be considered. And this, I know it's not fair because like English is not our first language, and when you read it, you feel like it's contraindicated. No, I would like you to pay attention to the wording because wording make all difference here. So here is not contraindicated, but like should be monitored carefully. But if you have other option, you don't give him the patient this retrocrystro tetracycline. Okay, so this is for digoxin and erythromycin. Last question from management. Like last two newsletter, I didn't give you any question from management, and I feel so bad. So I was like, no, I will give one management question here. Diabetic patient attend the clinic for dental treatment. You notice a fruity skin on his breath and dry skin. So let's stop here and decipher the information. So I'm telling you, he's a diabetic, and I'm giving you fruity, and I'm giving you dry skin. Again, intraoral examination revealed extensive periodontal destruction. So stop here. So if I'm asking you, this diabetic patient is controlled or uncontrolled? I think it's super easy for you. Even if you have no clue about this fruity stuff, okay, I will explain it now. But like he has dry skin and has extensive periodontal destruction, and I'm not like assuming the question said diabetic patient. Which of the following consideration is most appropriate? Advise the patient not to have a meal before future appointment to avoid gastric reflux and nausea. Maybe this happening from like the fruity one happening because of that. Okay, let's read the other option. The patient must be treated at the end of the day. No, this is not for diabetic. This is for the COVID patient. Minimizing the amount of epinephrine used. Again, this is not for diabetic. This is for cardiac patient. Avoid carrying out routine dental treatment. So these two are completely wrong. So between first one and third one, and this first one is completely wrong, and I'll explain it for you now. So here we come to conclude this patient, diabetic patient, uncontrolled patient, so we avoid carrying out routine dental treatment. So let me give you the idea about this fruity smelling breath. This happening for patient diabetic ketoacidosis from a ketogenic diet or alcoholic ketoacidosis. So this fruity coming from the ketoacidosis happening inside your patient body. This condition happens to three term, like most common term: diabetic patient uncontrolled, or patient doing ketogenic diet, or patient alcoholic with liver condition and stuff like this. So this one leading to your patient have this fruity smell. And as we conclude, the patient has other signs and symptoms to say this patient is uncontrolled diabetic patient. Here you should differentiate between hypoglycemia and hyperglycemia. Hypoglycemia is the most common. Hyperglycemia is not very common, but like again, glycemia is a sugar, is a fluid inside your, is the like a fuel inside your body. So if your car has a lot of good fuel and then you hit the gas, so you are good. You can run very fast, and if you don't have, you cannot run fast. So think about the same way here. Your body has no energy. So your body will be paler, you will be irritable, you will be hunger because your body want to get some sugar, lack of coordination, and sleeplessness. You are like on a downside. On the other way, hyperglycemia, it will be the other way. You increase stress because like you have a lot of energy inside your body and your body trying to dilute this one when you have water so you can urinate and then get rid of the sugar inside your body. You will have dry mouth pushing you to drink more water, weakness, headache, blurred vision, and frequent urination, as we said. Okay, so this is how to differentiate between hypoglycemia and hyperglycemia. This is extremely important. But for your knowledge, hypoglycemia is more common than hyperglycemia. Why? Because hypoglycemia can develop in like few minutes or few hours. Hyperglycemia will be developed like for days. It cannot be developed in 1 or 2 hours. It needs days for a patient to go to hyperglycemia. So let's wrap up the management for this patient, two type of patient. So we have insulin dependent type 1 and type 2. For type 1, defer surgery until diabetic is well controlled. Consult with physician. Schedule early morning appointment. Avoid lengthy appointments. Use an anxiety reduction protocol and avoid deep sedation technique in outpatient. Mortal pulse, respiration, and blood pressure before, during, and after surgery. Maintain verbal contact. If patient must not eat or drink, and this is important, before oral surgery and will have difficulty eating after surgery, instruct him or her not to take the usual dose of regular insulin. Start intravenous infusion of 5% dextrose in water drip at 150 milliliter per hour. So what this mean in English? So if your patient is type 1, and this is important, type 1, not type 2, and he will do surgery and he cannot eat, so you are asking him to skip the dose, you either him to alter the medication to go this one, which is like long-acting insulin, and you give him IV dextrose. Why? Because this patient cannot eat after surgery, and after surgery he need to rest, so he will miss his dose for this day. And as you can know, type 1 is more dangerous than type 2. You can see in type 2 is not. But if patient can eat, have the patient eat a normal breakfast before surgery and take the usual dose of regular insulin, but only half the dose of the insulin. So to wrap it up, for type 1, pay attention to this detail. Type 1, if he's going to do a surgery where he cannot eat, he will take the dose and then you give him intravenous dextrose 5%, 150 milliliter per hour. If he can eat, you will ask him to eat, and then you give him half the dose of his insulin, and then next day he can go to resume the normal insulin dose until they are able to return to usual level of caloric intake, activity level. So this is for type 1. For type 2 is little loose. Defer elective surgery until controlled, early morning appointed, and an anxiety reduction protocol, pulse respiration monitored, maintain verbal contact. If patient must not eat or drink before oral surgery and will have difficulty eating, instruct him or her to skip any oral hypoglycemic medication that day. And there is the only condition you are going to ask him to skip the medication. Otherwise, any diabetic patient, you will ask him to take his medication, eat his food, and then come to you. So the general guideline for any patient, you ask him to take his medication, eat a good breakfast, and then come to you. Otherwise, he's class 1, like type 1, and you're going to major surgery and he cannot eat, so we are going to do this maneuver. Otherwise, you go with the normal one. And then that's it for this newsletter. So for this patient, we are going to avoid carrying out any routine dental treatments. So today newsletter, I think you noticed like the energy is not very good in me because like Saturday I had some accident and I suffered a concussion, so it's really hard for me to do it today. But like Sunday is Sunday. Hope that was beneficial for you. Wait for the next 5 questions for the next week newsletter, and see you next Sunday. Have a good day.